Hi, and welcome to Concussion Talk Podcast. This is episode 47, and we'll be talking about concussion in women and girls. But before that, I would like to thank my sponsor, HeadCheck Health. HeadCheck Health bridges the gap in concussion care through simple and powerful technology. If you visit headcheckhealth.com, join organizations like the Canadian Football League, Trek Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada, who rely on HeadCheck to improve communication and optimize care. And now I'd like to, by the way, I'm McMaster, I'm the host of the podcast, so thank you again for joining us. And I'm talking to Meaghan Adams now. And Meaghan, you find her intro stuff here. She's very, very accomplished. So Meaghan is a VISTA post-doctoral fellow at York University and Toronto Rehab Institute, and assistant adjunct professor, clinical adjunct professor at McMaster University's School of Rehabilitation Science. She also does, for her research, Meaghan's the goal of her research is to improve rehabilitative strategies as well as metrics to return to work and activities of daily life by understanding the consequences of concussions on neural integrative processes and pathways. So, Meaghan, could you please expand on what I just jumbled up there?
You didn't jumble it up. You did a good job. Thank you for having me, Nick. This is great. Like you said, I'm a postdoctoral fellow, which means I am a full-time researcher. I work at Toronto Rehab Institute and York University, and I study people who have persistent concussion symptoms. By training, I'm a physiotherapist, and that's where I started my career. I worked full-time in clinical practice and saw patients who had brain injuries and required vestibular rehab. And in the course of seeing these clients, I started to ask some questions. Like they were telling me things that, they'd have trouble in grocery stores or big environments. And I knew that these things weren't cognitively demanding or physically demanding. So I thought maybe there was a chance that there was a sensory demand. And these questions about how people with persistent symptoms manage complex sensory environments, that led me to go back to school and do a PhD. So I did that while I was working and seeing patients, and it was awesome because the people that I was seeing in clinic really informed the research and the questions I was asking, and allowed me to kind of bring things back and forth between the clinic and the lab. And I finished my PhD in January of 2018. And congrats. Thank you. I started this position as a postdoctoral fellow. And my research now is, like I said, focused on people with persistent symptoms. And I'm still interested in the sensory issues that come after concussion. So I look at people some people whose symptoms have gone away and some whose symptoms persist, and look at how they manage to integrate vestibular and visual information, which can sometimes be challenging for people, and how they manage to integrate cognitive demands with a motor task. I'm particularly interested in people who are like working age, so not the high school athletes that seem to get a lot of attention. And because of where I work, I get to use some really cool tools. So at Toronto Rehab, we have virtual reality. Nice. A really cool virtual reality setup.
Is it immersive or?
Yeah, it's a big 240-degree screen, and we can put a treadmill in there or a force plate. I use the force plate, but there's some really cool technology that we have access to. And then at York, I'm working in a lab that places a really big emphasis on tablet-based computing, and making objective assessment tools that are portable and easy to use in clinical settings. So, and that's, I think, a really important part of concussion management that we can talk about more if we're interested later.
Cool.
Yeah. So, and that's
sorry, me head off there.
Yeah, don't be sorry. It's all good.
Yeah. So I noticed that. So you're saying the sensory, the sensory system. But do you still have a clinical practice, or do you concentrate mostly teaching and research?
Yeah.
And also, actually, well, I just integrated. I saw on Instagram that you posted about the biopsychosocial model for research for brain injury.
Yeah.
So, and I think that actually can hopefully, well, I think it goes well with this next topic, which the main topic of our conversation, which is concussion in women and girls. And actually, I read on your blog, One Brain Neuro, which is onebrainneuro.com. It was an article you wrote last March, International Women's Day, March 8th or 4th or whatever it was.
Yeah, it was something like that. I can't remember.
It was about concussion in women and girls. And so what did you, I mean, obviously you're interested in this topic is for personal reasons, but have found there's like an obvious connection between your research into integrative processes and concussion symptoms and lingering symptoms for women and girls, or?
Yeah, there is. What the research is starting to show, it's coming out slowly, but it is coming out, and we're seeing that women and girls are particularly at risk for persistent symptoms, which is what I look at. Sensory changes in people whose symptoms don't go away the way that we'd expect, and women and girls are more highly represented in that group. So, for whatever reason, there are a couple hypotheses, but for whatever reason, women and girls tend to report more symptoms and more severe symptoms than similar groups of males. And there have been, over the past decade or so, a number of different theories about why this is. The research that's starting to come out now that I think is really interesting is there may be a hormonal connection.
I read about that yesterday as well.
Yeah.
The progesterone and the one there's
estrogen and progesterone.
Yeah.
And it seems to, so the levels of those hormones fluctuate depending on where a woman is in her menstrual cycle, and there seems to be some idea that where a woman is in her menstrual cycle at the time she sustains a concussion has something to do with how long it will take to recover in some cases. So, and the natural connection from that is hormone levels are probably involved.
Have you noticed anything when you're doing research with female participants in your studies about sensory? The sensing and complex integrated processes and sensory, have they sensible around them? Have you noticed any connection between menstrual cycle, the progesterone hormones, and
that's one of the things that we want to look at. We're going to do hormonal assays in a subset of our patients. The studies that I'm working on right now aren't finished, so I don't have conclusion stuff. But we are going to do hormone assays in a subset of these patients who are female and who are having persistent visual and vestibular symptoms to see if we can get some more information. Because at this stage, it's really at the information gathering stage.
Right. So for women and girls, I know you mentioned in the article that you don't, in the article you wrote, Concussion Women and Girls, which I just have up now, you mentioned that in that particular article you wrote, you don't distinguish between gender and sex because of just for that because there's interplay, as you mentioned. But do you find, is there any connection between the gender and biological sex for what do you think is the main driver for, or you can't say now, so don't forget that question. Um,
It's hard to say. Like
yeah,
the one hypothesis is that um, these differences in symptoms uh, these differences in presentation between females and males have to do with hormone levels. And in that case, we're looking more at biological sex,
yeah,
like that's, hormone levels. But gender refers to how people are socialized and
yeah.
how they identify.
So
And
reporting levels, what you're thinking of, like suck it up, or women are more
yeah, we
inclined to,
socialize.
yeah,
Yeah. Yeah. We socialize um, males and females differently, right from birth. So,
yeah,
um, the trouble is these studies are so early, like we're so early in the journey that we don't know if it's sex that matters more or gender or both, or if we're completely on the wrong track altogether and we need to be looking at something else. But it's only in the last few years that people have been asking these questions, so I think we're on the right track to kind of do better by our female patients.
because I know most of the research is obviously in like in male, like hockey players and football players and questions from the pro leagues or whatever. So but also women, the females have not been studied as like it's not a 50-50 study, obviously. But I mean, in labs that are not doing research on sports, is there more of a 50-50 balance between participants? Like, is there more even?
Yeah, it's more evenly represented, and people are starting to recognize now that there are probably differences between men and women, differences that we don't understand. So they're trying to do we as researchers are trying to do a better job of getting samples that are evenly representative of males and females, and analyzing them to see if there are group differences rather than putting everybody together and just analyzing it all as one big
Yeah.
data set.
So you're trying to get a bigger data set of the women, of female women and girls, I should
Yeah.
say, female.
Yeah.
So for your integrated processes and your what else are you doing, your integrated processes and just how that works in sensory
Mhm.
issues. So how do you is there a way that you do it to make it different for men and women, for male female participants in your research?
No, I don't set up the studies differently for males or females.
No, because
Um,
that would bias results. But
yeah, um, I mean it's a good question. It's a legitimate question, and it's probably something that we may need to do down the line. But as of right now, um, no, everybody goes through the same protocol, and then I look at, and I'm making sure that I have even numbers of male and female participants, so I'm not overly biased toward one or the other. And then looking at the data and analyzing differently, or not analyzing differently, but analyzing the two groups separately,
yeah,
as well as putting them together so that I can compare between the two groups. Um, I do have another project that's in the works. It's just sort of in the ethics stage, and that's the one with the hormone assays. That one
okay,
will just female
okay,
participants because
and
we're looking at differences in hormone levels.
right, that makes sense. So actually, I was just reading this section. You mentioned that you started off your interest to get back to a PhD from your physical therapy, your PT thing was persistent, no, of persistent symptoms, and no, and you as you mentioned in your article that there women and girls tend to suffer longer with post concussion syndrome or post concussion disorder. So is that what did you notice that when you first said, oh, I want to go back and do what did you notice? So it was women or just thought, oh, this whole area of subject matter is interesting.
It was a little bit of both. I had a caseload that was definitely more. I definitely had more women on my caseload, more female patients.
Yeah.
it was hard to tell if that was just because like I'm a woman and they felt comfortable with me, or what the reason was. Um, but I had I had some really interesting patients who, some of them were pregnant and having trouble, and then they delivered the baby and their symptoms got better, and there were some hints at that point that hormone levels mattered. Um, and But it wasn't specifically a sex or gender question that brought me back to my PhD. It was like, why are these people having persistent symptoms? Why do some people get better and some people don't? And then just delving into that question a little bit more kind of made me think, or made me recognize the sex and gender differences.
And you hope to find out more from your hormone assay as well about
Yeah,
that.
that's one of the
And
things.
speaking of the hormone assays, is for pregnant women or women in pregnancy or nursing, have there been, and obviously there haven't been hardly any studies on females,
Nope.
but there's been nothing about
Nope.
how that affects or how
Nope. There's
they
absolutely nothing, which
that's
is,
a
I know, isn't that crazy?
that's a lot of stuff.
I went to a talk a couple years ago with one of the researchers who's kind of leading the research in this area. He was part of the group that did one of the early studies on hormone levels, and that was one of the things I asked him, because I was treating patients who were pregnant and who were not a lot of them, but I had a few who had brain injuries while pregnant or concussions while pregnant, and or got pregnant later, and there's just not enough of them. There
No.
haven't been any studies. It's hard to clear those kinds of things through ethics, because as soon as you say, pregnancy in vulnerable populations, people
Right.
get kind of scared.
Yeah.
But they're questions that we need to ask and studies that we need to do.
Which makes the other one, the question I was about is you mentioned with your last headline in your article, is that they concuss differently. They're concussed differently. And that's another area where it's difficult to get the ethics thing would be difficult to get around, but work with. But the domestic violence and women, because men can just say, oh, I got hurt playing hockey or playing soccer, I fell down, or I got head to head or elbow to head or whatever. But women or mostly women who are obviously victims of domestic violence, I mean, that's an issue that they necessarily don't even let people know, and so that must be very hard to get, and that's an important issue, important population, I would think.
Yeah. I mean, women do get concussions in sports and work injuries and all kinds of things, but there is a subset that get brain injuries related to domestic violence that there are some groups out in Vancouver. There's a group of researchers that are focusing particularly on that, and it's important work for a whole variety of reasons. There's social reasons, and then there's the scientific side of it too.
And you've just done mostly research with women who are working age, you said, but so
that's my focus right now. Yeah, my past work has been on sort of age 20 to 30, but I think if we look at this working age population, they're huge contributors to the economy, and that's when there are hormonal changes for women. And when I say working age, when I say working age, I mean like age 30 to 60. So you kind of capture that menopause stage. You don't get the teenager years, but I think those years are represented well in other research projects, and this is just the one that I'm focused on at the moment.
With so many issues are with menopause, with childbearing years, with domestic violence, and there's so many issues to delve into with this in the age population. You were saying 30 to 60 especially.
Yeah.
So, but before that, for say strength and this could be in women and girls from teenage years upwards. Have you noticed any difference in like this? Do you think this makes strength and size as a
There
uh,
that may have something to do with it. Different studies have shown different things, but there is the idea that women have
smaller
smaller necks,
smaller
smaller
frames?
frames. Yeah.
Yeah,
For a while, people were saying, like women's hockey is supposed to be non-contact.
yeah,
So
which is
if you get a hit playing hockey in a non-contact league, maybe you're less prepared for it, or you don't expect it, or um, and all of these are ideas. Some of them are there's more scientific basis for some of them than others. And I think right now the one that I'm most interested in, obviously I'm biased, but I'm most interested in the hormone hypothesis.
right.
But,
Yes. So
yeah.
actually, do you play any or do you play any sports that
Yeah.
are particularly hard on the body?
Well, I when I was in high school, I was on the rowing team.
Okay, that's not.
So there's not really much concussion risk
No,
there.
I don't think so.
And I right now the sport that I spend the most time doing is running, but I've in the past done a lot of cycling.
Okay,
Um,
which I know as well.
you
Yeah,
know a lot about that, yeah.
yeah.
And
Well, a
I
lot,
did well. You've had
yeah,
more
but
experience than
not
most.
not not a long time though. Just a long time, one time. Like
Yeah.
not, not a bunch of years.
Um, and then I did when I was, it was probably 10 years ago now. I did a women's learn to play hockey camp because I had never learned to play hockey, and I decided at the age of like 27 or 28 that I wanted to learn. So I did that for
Yeah.
one winter, and that was really fun. I was really, really terrible, but it was a really good time.
Was it rough? Do you think have you okay? Well, that's two kind of combined question, I guess. Have you ever had a concussion?
No, I've never had a
No,
concussion. No,
not from any of the because gym hockey for that long and
no,
running won't get it unless you
not really.
have a bad fall and
Yeah,
run.
no, it was so I got into this because I was when I started my physio career, I had thought I was going to be a sport physio, and I was going to be on the sidelines and work with athletes and travel with teams. And
Right.
I did a fellowship at the Fowler Kennedy Sports Medicine Center in London, which was a fantastic experience.
London,
Uh,
Ontario.
London, Ontario, yeah.
Ontario, Canada. Okay.
And that allowed me to I got exposure to all kinds of different areas of physio, and in Canada we have certification exams. So I was preparing for my sport physiotherapist certificate exam, and concussion was part of the curriculum, part of the stuff that I had to learn. And I hadn't really been exposed to it while I was in school. We didn't really talk about concussion. We talked about more severe brain injuries and the movement requirements, but we didn't cover concussion very much. This was a while ago. I mean, I graduated from physio school in 2008, so things have changed since then. But
Yes.
and I found it fascinating. I thought this was so interesting, and this injury was like it just for whatever reason, and I still don't really know why, I got hooked. Um, and I was able to see a few patients with concussions while I was doing this fellowship, and I learned some things that could help in the rehab process. So when I finished the fellowship, I got a different job at a sports medicine clinic working with a sport physician. And I talked to him, and I convinced him that, physio could help some of these patients. And he referred a few, and I started to do rehab with them. And this was all around 2011, 2012. So Sidney Crosby at that time was
Okay. Yeah.
recovering from it. So concussion was everywhere. It was in the
Yeah.
news. And so I started, like, patients started to come in. They started to realize that, they didn't just get their bell rung, and they shouldn't just shrug it off and keep going. So I started to build up this practice of people who needed help. And that was when I started to see patterns and commonalities and ask questions. And I hadn't intended to do a PhD. I just wanted an answer to some of the questions that I had. But going back to the literature and the evidence, the answers weren't there. So I decided I would do a study, and it turned into a PhD.
Oh, yeah. Did you just study before you decided to go to school, or you just study
Well,
to go to school? You did a study. Like,
I
which
I
came first? Kind of
decided
thing?
I decided I wanted to do this study. I wanted to ask these questions, and I there's and that's great when you kind of like have the idea, but the logistics of it are like, when you delve into it, they're not that easy. So I needed,
You need the university.
I needed resources. I needed a supervisor. I needed
Yeah.
somebody's advice.
Right.
And I contacted a professor that had taught me during my physio school. And I said, look, this is what I want to do. This is the question I want to ask. Can you help me?
Yeah.
And she said, well, if you're going to do all that work, you might as well get a credential. You might as well turn it into a PhD. And I was like, no, but I don't want to register in the university and like all of that. I just want to do this study. And she's like,
send me the results.
think long and hard about this, because funding, who's going to pay you to sit around and do research when you're not seeing patients? And I was like,
Right.
oh, that's a good, so it did, there were some advantages to doing it as a PhD, but in my career since then, I spend a lot more time educating clinicians and physio students now. And my advice is, if you are interested in getting involved in research, you don't have to do a PhD. Like I did, that was kind of how things went for me. But in my research that I do, I am always looking for, clinician collaborators, because my clinical experience has really informed the work that I do now.
Right.
And
yeah,
if people, I say to people all the time, if you're a clinician and you want to get involved with research and you don't want to take on a PhD, you don't want to do the whole thing, like reach out to somebody who's doing stuff that you're interested in, because I am sure any researcher would be thrilled to have a practicing clinician help them out in any way that they can.
That's great advice. Yeah, and to generalize, which I know you shouldn't generalize, but I will on this point. There are more females in the physio school and rehabilitation school, as you noticed at McMaster. So have you noticed that there's more interest in females and concussion in your rehabilitation school? Is there more?
I haven't asked, actually.
No.
I haven't asked about the female question specifically. But when I work in the physio school, I do problem-based learning tutoring. So I get to work one-on-one with a small group of students. And when I tell them what I do, they're the males and the females are very interested and have lots of questions, particularly after they've been out on a placement and they've seen patients. They come back and they have lots of questions and how things work. And
that's gotta be valuable.
Yeah. There definitely are. I mean, my physio class we graduated in 2008. There were 46 of us in the class, and I think 6 were guys.
Okay. Yeah.
So definitely at that time, and it still is now, the ratio might be a little bit better, but at that time it was very skewed toward women.
Well, yeah. But that would also help shape this new area of research you're hoping to get into. And speaking of this area, so I mentioned before your Instagram post on biopsychosocial model for brain tree. So can you explain what that is, exactly what you're hoping to do with that model?
Yeah, sure. That's the rehab professions, and I think medicine more generally, we're starting to recognize that people are maybe more complex than just the condition that they have. We're not starting to recognize that. We've always known that, but we're doing a better job of acknowledging it now. And thinking about a condition or an injury or a client in terms of a biopsychosocial model means that you're thinking about how their biology is affected. So in the case of brain injury or concussion, the biology is affected because there is a brain injury. Something has happened to a biological structure. The psycho and social parts of a biopsychosocial model refer to the fact that the injury doesn't live in isolation. So there's, again, coming back to a brain injury, because that's kind of how I framed it in that model you're talking about. There's this injury to the brain, which is a biological structure, but that has psychological effects. And the combination of those two things impacts a person's social life. So when you think about an injury, or the patient in front of you, if you're a clinician, you need to think about all of these aspects. You can't give somebody, or you shouldn't give somebody, a whole bunch of rehab exercises and homework when they have social responsibilities, they have family or other demands on their time. And you need to consider how the words that you're using affect the way that they feel, because an example of this is we're trying as a community to switch from saying post-concussion syndrome or persistent concussion symptoms to prolonged concussion symptoms, because the vibe with those words is a little bit different. When we say somebody has prolonged symptoms or they have post-concussion syndrome, it's like,
or they still have them,
they have it's a diagnosis and it's really heavy and they're living with it. If we say that your symptoms are prolonged, there's more hope with that. They're taking a long time to get better, but there's no implication that nobody's implying that they're not going to get better. And that's part of that psychological part. We need to acknowledge how our words affect the way people feel.
Right.
And so I made a biopsychosocial model. I first heard about it from a pelvic floor researcher who does research on pelvic pain and stuff, and it was about how pelvic pain affects all aspects of people's lives. And I've thought about it for a while, and it applies just as easily to brain injury. And
which makes a lot of sense.
Yeah, for sure.
Yeah.
I teach courses to clinicians, and I wanted to somehow include that or encourage that type of thinking in the people who take my courses. And I was trying to put together a model, and I put it on Instagram because there's so many really, really smart, engaged clinicians and scientists on Instagram who I've connected with and have given me, I've learned a lot from. And so I thought if we put that out there and they can kind of tell me how to tweak it or make it better before I pass it around to more people, that would be valuable.
Yeah, I've tried to share it too. I think it's very important because also when I had my brain injury, that was before you finish your physio school, but there was not much was in a brain injury and concussion and well, also I ended up having fantastic. My physiotherapists were all great, and I had one Jen Shears who was just amazing. But and she knew a lot about neuro rehab, but there still wasn't in the medical community in general. There wasn't much knowledge about brain injury, and except obviously the neurosurgeons and that knew a lot. But I mean, but there's the biopsychosocial model was not around then. I'm not a medical professional, but I mean, didn't seem to be around as much then.
Yeah, it's and I think I don't know if it's social media or the internet, but we're getting the lived experience of patients is becoming more and more a part of the research work that I do, as well as like policy around concussion. So there's a lot of legislation now trying to make sure that we handle things better and that patients get access to early intervention. And I sit on a couple committees, and all of them have representation from people who have lived experience with concussion, and like yourself. I think it's really, really valuable.
Yeah. Is there representation from, say, just a female perspective, or is it just they just have groups that say sport and work and whatever? Do they have those and not necessarily female perspective, or
Um, well, it kind of varies depending on the goal of the committees, but there's representation. I'm not on any sport focused committees at the moment, but before it used to be like researchers and clinicians, and that's who was making the decisions about
yeah,
how we should handle things. And now there's always at least one, usually more, people who have been through the system who can tell us, like, this is what works and this is really what doesn't. So that, hopefully we're doing a better job of serving the people who actually need these services and recommendations.
yeah. I mean, there's so much work to be done in this
Yeah.
Christian women and girls, especially, and also just in brain injury in general. So what you're doing. So yeah. So I really hope that I can find more people involved in research and Christian women and girls who want to talk about this important issue. So yeah. So thank you so much, Meaghan. And is there anything else you wanted to talk about? You wanted to mention?
I think that was everything. If people want to talk to me more, I have a Twitter account, which is at Meaghan Adams PT. And like you said, I run One Brain Neuro, which is I do courses and clinical consultations for people, like for healthcare practitioners and fitness professionals who work with people who've had brain injuries. So you can find me there as well.
And what is that? What is that site? Or is that those
It is.
Embodias?
I teach the courses through Embodia, which is an online education platform for healthcare professionals. But my personal website is www.onebrainconcussions.com.
And I'm on One Brain Neuroscience right now.com.
Yeah, it directs to the same thing.
And MeaghanAdams.com is where I can find out more about you and what you're doing.
My research
On
is,
how up to date is that? I'm not sure if is that research.
That one is, yeah, that's up to date.
Okay, well, that's where I got most of my research for my little
Perfect.
snippet about you, but and intro. So thank you so much, Meaghan, for being on this podcast, and hopefully women and girls involved in concussion or who have had concussions will reach out to you, or hopefully find someone who knows something how to help them better than just general. Maybe there is, maybe there's not, but maybe there's better research they found. So hopefully they're at least sparking interest in that. Hopefully this podcast will spark interest in that, and more podcasts to follow. So thank you so much, Meaghan.
Thank you for having me. It's been fun.
Thanks. Thank you again to Meaghan Adams, and please find her on Twitter or at her website at One Brain Neuro. Please visit me on Instagram, Twitter, or Facebook at Concussion Talk, and please visit my website at www.concussiontalk.com. Thanks so much for listening, and hope you listen again soon. As always, music at the beginning of this podcast is by Ben Sound, www.bensound.com.